speaker is another student of mine. Would you believe I'm so old? And these are all the students that have come to pass in the University of the Philippines. She is a pediatric infectious disease and is now director of the Institute of Herbal Medicine at the National Institutes of Health, University of the Philippines. She is also a pharmacologist. So she's not only a pediatrician, she's also a pharmacologist and is actually a member of a lot of drug and drug interactions. As much as possible, she's always there when you talk about drugs and even approvals for the government. Ladies and gentlemen, please welcome Professor Cecilia Maramba-Lazarte. Take it away, Cecil.
Good evening. Thank you for this invitation, Dr. Lulu Bravo and the ADVA team, and it is my honor to participate in this symposium. We'll be talking about dengue in the midst of the COVID-19 pandemic. So what we'll be talking about in the next 20 minutes, co-infections and co-epidemics with dengue and COVID-19 are very serious health concerns. Can dengue and COVID-19 coexist in the same patient? And we have a little data of dengue and COVID-19 in pediatric patients in the Philippines. And how has the COVID pandemic affected the prevalence of dengue in the Philippines? Of course, we have to move, and complacency is not an option for either of these disease entities. Unfortunately, COVID-19 and dengue fever have many similarities, which sometimes makes diagnosis difficult. They also have their differences. They have overlapping signs and symptoms, such as fever, headache, rash, cough, pharyngitis, and even agnosia or dysgeusia. Cough, chest pain, cyanosis, and rhinorrhea are more prominent in COVID-19, while retroorbital pain, purpura, persistent vomiting, and abdominal pain are more prominent in dengue, as you see here in the highlighted yellow boxes. Unfortunately, both infections can also cause shock. So can co-infection exist both diseases in the same patient? Well, there is this first case report in the Philippines of an adult, and this was in August of 2020, a 60-year-old female with hypertension from northern Luzon. She had body malaise and high-grade fever already for 2 days. She complained of headache, generalized body ache, myalgia, and arthralgia. She took paracetamol with temporary relief of her symptoms. On physical examination, she was febrile with decreased breath sounds in the right basal area. She had no history of travel outside her community, but went to the market 3 days prior to the onset of the symptoms. With this, she was admitted to the COVID-19 ward as a COVID-19 suspect. In the COVID ward, the patient's social and environmental history was further investigated. The suspicion of dengue was considered when she volunteered the fact that dengue cases were present in her neighborhood, with the latest case occurring 1 week before her symptoms commenced. The patient could not recall having any previous dengue symptoms or infection. The patient was positive for dengue NS1 antigen, but negative for both IgM and IgG. The patient was then managed for suspected co-infection with dengue fever and COVID-19. The next day, her RT-PCR showed a positive test for COVID-19. A repeat of her blood count showed a drop in the platelet from an initial of 156 to 85. There was also persistent leukopenia at 2.85 and an increase in the lymphocyte count. The patient consented to receiving favipiravir for 13 days. Later tests showed further decrease in her platelet count, falling to 37. On chest scan and X-ray showed posterior basal pneumonia with features atypical of COVID-19 with pneumonia and some minimal pleural effusion. So they named it as atypical because the typical would be the bilateral ground glass opacity seen in the periphery of the lungs. On the 5th day of hospitalization or the 7th day of illness, maculopapular rashes appeared over the patient's lower extremities, with some areas of erythematous petechial confluence and islands of normal skin. Her blood culture was negative. A repeat test for dengue IgM, IgG on the 8th day of illness was positive for IgG but negative for IgM. A repeat chest X-ray on day 9 of illness showed regression of previously noted denticities in both lobes. On succeeding days, increasing trends in the number of platelets and leukocytes were noted. Another dengue IgM IgG test was done on the 10th day of illness, which yielded the same results. After 10 days in the hospital, the patient was discharged with her symptoms improved. So apparently, she had a secondary infection at the same time, the COVID infection. How about in children? Does COVID-19 and dengue co-infections occur? Let's look at our own Philippine data. We call this the Salvation Registry, no? And this registry was actually my brainchild to capture clinical and epidemiological data of confirmed COVID-19 Philippine pediatric patients. And we have a whole team that is running this. Uh, it is the surveillance and analysis of COVID-19 in children nationwide. Short is Salvacion. We named it to honor our dear mentor, Dr. Salvacion Gatchalian, who many of you in this dengue community advocates know and love. And she had the misfortune of succumbing to COVID-19 while she was the president of the Philippine Pediatric Society. So we have also other collaborators here, the Philippine Pediatric Society, our own PIBSP, and the database was made by the National Telehealth Center. And our team is led by Dr. Abby Chong, Dr. Cheska Pantig, Arlene Lee, and Dr. Ivy Rosales. So this is just the first bulletin, which we came out in April 30 of this year. So pediatricians, general physicians, okay, or healthcare workers can submit to the Salvation Registry and put in all the answers to the forms in the forms that are here. No, and this was our initial bulletin in April. No, but now, as of May 31, we already have 972 distinct patient submissions or cases, although this is a small portion of the 19,000 plus cases in children reported. No? And for now, we are still actively soliciting submissions from our colleagues in the Philippines. So here, looking at, from the registry, looking at the disease severity, from this sample, 20% were asymptomatic for COVID-19, 38% were mild, 25% were moderate, and 10% or less for severe and critical. Now, this is a somewhat biased sample wherein the submissions are mostly hospitalized patients, no? So, admitted patients make up more than a little over 90%, and outpatients at 9%. So we're encouraging more and more our colleagues to please submit your data. So for the pre-existing conditions, no, highest were hematologic oncologic diseases at 7%, neurologic diseases at 5%, and cardiac disease at 3%. And for the outcome of the COVID-19 patients submitted, 82% recovered, 10% were deaths, and 8% were unknown. Now, we also have a section for concurrent infections in the registry. No? So, highest is sepsis at 7%. Dengue fever is next at around 3%. And healthcare-associated pneumonia at 2%, and a sprinkling of your tuberculosis. So indeed, we have patients with COVID-19 and also infected with dengue. So of this 900 plus 32 dengue cases were reported, although the laboratory tests for dengue are only known for these 9 patients. No? So here we have 5 patients confirmed by your dengue NS1 antigen. Okay, a few confirmed by your positive IgG, and the rest a combination of those. So here we can see that those who got dengue, majority were male, okay, 3/4, and 25% are female, and the median age is 11 years old, okay, and the age range from 9 months to 17 years. Why males? Well, maybe during this lockdown, they are the ones who go to the market or are working, maybe, no, are out of the house more. No? These are just hypotheses that I am generating here. In terms of the COVID-19 disease severity classification of these patients with dengue co-infection, 34% were mild, moderate was 37%, severe was 18%, and critical was 9%. How about their clinical presentation? No? So there are a lot of overlapping, again, signs and symptoms, but prominent here, no? Of course, all of them had fever, but abdominal pain was seen in more than half, as well as decrease in appetite, as well as vomiting. Cough was not very prominent in these patients. Okay, so what's the problem with co-infections? There may be a difficulty in recognizing both infections because of these overlapping signs and symptoms. No? So you may miss one of them and not correctly manage these patients. Misdiagnoses have occurred. No? There were reports of 2 patients with false positive dengue results in Singapore. So there also may be a delay in treatment, no? As well as following the correct infection control procedures if either of the diagnosis is missed. No? So a dengue patient put in the dengue ward where in fact they have COVID COVID-19 and they might be spreading COVID-19 or vice versa, no? So also there is a question of, is there an increase in the severity of either disease if you have a co-infection? Very hard question to answer. But so far in the outcome of our patients with co-infections, uh, they had recovered and sent home in around 87.5% of the patient. There was one patient who went home against medical advice, so we presume this may not have had a good outcome. And there was mortality in 3 patients. Now, uh, comparing to the outcome of the COVID-19 infections without dengue, they seem to be similar. So let's look at these deaths. No, Dr. Cheska Pantig was so helpful in tracking down these cases. The first one was from northern Mindanao. The patient had severe dengue but was already recovering when the patient also had critical COVID, and apparently the cause of death was due to the COVID. Another case was from a hospital in Quezon City. The patient had severe dengue. The patient died on the 7th day of illness. On admission, they usually do routine RT-PCR, which was positive. The patient also had pneumonia, but it is not clear if the COVID was contributory to the demise of the patient. The last case, we are still tracking down what happened to this patient. How about co-epidemic? The concurrent circulation of dengue and coronavirus disease may produce many unfavorable outcomes, such as we already mentioned, the co-infections, the delay in diagnosis and treatment, and delaying mitigation measures, overwhelming the healthcare system, and under-reporting of cases. There may also be a deterioration of surveillance and control interventions, and also exacerbation of social inequities. Indeed, the lockdown is greatly compromising the effectiveness of vector control. So, especially your social mobilization campaigns and preventive insecticide spraying in private homes may be delayed or not even done at all. No? So there was a modeling study done. So it was an agent-based model of your dengue virus transmissions, no, in this paper, using the city of Iquitos, Peru. And in their model, 70% of the population was on lockdown. And in this model, it actually showed an increase of about 10% of dengue virus infections. So, but of course, this is theoretical. It is a model. How about in the Philippines? What happened? Well, there was actually an outbreak called in 2019, no, because of the increase of cases from January to July 2019. So, okay, pre-COVID, there were 167,607 dengue cases, which was twice that of in 2018. The case fatality rate was 0.43%. Although it was lower than 2018, it was still higher than the average in the Western Pacific region. So the DOH declared a national dengue epidemic in August 6, 2019. And they urged all regional DOH offices, okay, to step up dengue surveillance, case management, and outbreak response, to have cleanup drives and vector control in health facilities and communities, and conduct the sabayang 4 o'clock habit para sa dengue out. So, what is the 4 o'clock habit? No? This is the social mobilization wherein everybody, all citizens are asked to clean up no, their surroundings, their own areas, in places where breeding sites of mosquitoes could be, no, so that we would eliminate where the vector would propagate. So comparing 2018 to 2019, here the blue columns are 2018 and your red columns are 2019. No? So we can see really the rise in cases as the weeks went on, leading up to July and August uh, of 2019. No? So we can really see that it is an outbreak at this time. Now, how did our COVID-19 lockdown actually affect the dengue cases in the Philippines? No? So let's switch a bit. Here, our COVID 2019 is in blue. Okay, so if we look through the months, and this really shows the outbreak, no, in 2019, wherein the heavy rainfall is seen in the months of July, August, no, and we see that peak, okay, a few weeks after that, and the peak was having about 13,000 cases that week of week 34, no? But as the rainfall also subsided, it looks like the cases also subsided. So that's the blue for 2019. How about for 2020, which is your red dots? Okay, so this seems to be a bit of the continuation, no, from 2019. Okay, having some cases here with the uh, highest in week 4, which is still January. Okay, and as the rainfall goes down and into the summer months, no, we generally see a decrease in these cases as seen in 2019. No, and as we went into the epidemic here, which may be around, okay, week 14, 16, okay, and lockdown was placed in place, we see really a decrease in the number of cases, no? And of course, what will they say? Oh, maybe they weren't diagnosed properly, or maybe they weren't reporting. I don't think so, no, because of course, I'm also on the ground and have my own duty days in the hospital, and it was pretty quiet really for dengue, but not for COVID, of course. Uh, and people are already very good at diagnosing dengue, no? So maybe it is a bit underreported. Maybe some of them wouldn't go to the hospital if they have mild disease, no? This might be underreporting, but I don't think it really shot up, nor did we have an increase in deaths in dengue during this 2020. Okay, so looking at the cases at the end of 2019, more than 437,000 reported cases. And at the end of 2020, only 83,000 plus cases. In terms of mortality, there was uh, 1,607 deaths in 2019, and in 2020, only 324 reported deaths. So what are the reasons for this decrease in incidence of dengue in 2020? No? Is it really just because of the people afraid to go to the hospitals? Um, I'm sure the mild cases, they wouldn't go to the hospitals, but if these patients are severely ill, no, of dengue, for sure we would have seen them in our hospitals. No? So there was not an increase in deaths, low rates of diagnosis may be for the milder dengue, but probably not for the more severe ones. How about having our children at home? No, so this leads us to think about the transmission in children, which was really found to be high in schools, no, during outbreaks, no, and cleaning up the schools actually helped control the outbreaks. Also, keeping these children at home and less mobility for the majority of the population would lead to lower rates of transmission, no? And of course, uh, lower rates of travel and all that would also lead to lower transmission. Were there a lower number of vulnerable individuals? I don't think so. Okay, how about for other countries? Maybe our ASEAN and Asian friends can correct me if there is some wrong information here. But from what I've seen, their lower dengue incident based on the ADVA dashboard, which is so helpful. Go to the site. Cambodia, Laos, and Malaysia overall had a lower dengue incidence. But higher dengue incidence was reported in Singapore, Brazil, Indian Ocean Islands, Bolivia, Honduras, Mexico, and Paraguay. So, different places may have put in place different kinds of lockdowns or different mitigation strategies for COVID-19, which may have promoted the transmission of the virus. Now, what does this tell us? No, it tells that although now in the Philippines we may have a low incidence, no, but as we open up our economy, as we change our mitigation strategies, no, as people get vaccinated and are allowed to other places, we should not forget about our dengue control measures. At the same time, in implementing these dengue control measures, we have to adopt them so that we should also prevent COVID-19. No? So, for example, let's say for uh, eliminating non-permanent breeding sites, which is found to be highly effective in controlling dengue with a moderate strength of evidence, okay, and in doing some of these mitigation strategies, such as households encouraging to work together to get rid of stagnant water or reduce solid waste, no? So uh, these activities may actually increase the incidence of COVID-19, no? So while still practicing these mitigation uh, practices, we should adapt and put into place things like physical distancing while doing these activities, wearing masks or shields, okay, and reduction of contact time with people, okay, while doing these activities. So we shouldn't stop our dengue control measures, but rethink, no, in doing them, are we uh, promoting COVID-19 transmission, or can we adopt some measures to prevent transmission? So again, there is no room for complacency for either infection, dengue or COVID-19. Okay, for dengue, uh, physicians should have a high index of suspicion in diagnosing dengue, especially in the coming months in the Philippines of high rainfall. Okay, infection control for both diseases should be top of mind. Surveillance for both diseases should still be implemented. Vector control measures should continue in compliance with COVID-19 prevention. Adequate resources should be allocated to prevent and manage vector-borne diseases, and advanced preparedness in essential health care systems and hospitals. So this is what we talk about, co-infections in our children and adults. It does not seem to increase severity in either illness, but we should wait for more data to definitely conclude this. And missing the diagnosis may lead to delayed management or incorrect infection control measures. Co-epidemics may happen. There are multifactorial events which may increase the incidence of one of your dengue or not. Okay, some countries have some dengue endemic countries have experienced this, so there is no room for complacency. So these are the references that I've used, and just to quote from Martin Luther King, there is such a thing as being too late. This is no time for apathy or complacency. For dengue, this is a time for vigorous and positive action. Thank you very much.